Hello, everyone, and welcome to our module on aortic disease. Let's start by talking about aortic aneurysms, which are very common abnormalities of the aorta. So an aneurysm refers to a dilation or a bulge of the aorta. And recall that the walls of blood vessels, including the walls of the aorta, have three layers. So if this is the blood on the inside of the aorta, the layer that is up against the blood is called the intima. That's followed by the media, and that's followed by the adventitia. And so in aortic aneurysms, all three of these layers become stretched and bulge outward, and that's what forms the aneurysm. Aneurysms in the aorta are classified by whether they occur in the thorax, which is above the diaphragm, so up in this region here, or below the diaphragm, which is in the abdomen. And of those that occur in the thoracic area, you can divide those into those which involve the ascending aorta, which is this portion right here, or the descending aorta. And so in this video, we'll talk about the different types of thoracic aneurysms. We'll also talk about abdominal aortic aneurysms. So we'll start with thoracic aortic aneurysms, which, as the name implies, are aneurysms that develop in the portion of the aorta found in the thorax or above the diaphragm. Usually these aneurysms occur in this part here, in the proximal or ascending aorta, just above the aortic valve, which is found right here. These types of aneurysms are strongly associated with hypertension. High blood pressure over time can weaken the walls, and that's what leads to development of the aneurysm. And also a pathologic process called cystic medial necrosis, and I'll talk about what this means in just a second. In addition to hypertension, these thoracic aneurysms are often seen in association with other disorders. For example, Marfan syndrome, which is a connective tissue disorder I talk about in the cell biology section, that commonly leads to aortic aneurysms in the thorax. Turner syndrome is a genetic condition I talk about in the genetics section, but children born with this condition can have coarctations of the aorta. They can have bicuspid aortic valves, and they also can develop thoracic aortic aneurysms. You should also know that anyone who's born with a bicuspid aortic valve is more likely to develop a thoracic aortic aneurysm. And that's because when the aortic valve, which is right here, develops abnormally, it leads to weakening of this wall above the aorta, and that predisposes to an aneurysm. And then finally, it's very rare in the modern era, but tertiary syphilis can cause aortitis or inflammation of the walls of the aorta. And so 50 or 100 years ago, when there were no treatments for syphilis, syphilis was a common cause of thoracic aortic aneurysms, very rare today. It's high yield to know for the step 1 exam that cystic medial necrosis is a pathologic process strongly associated with thoracic aortic aneurysms. So cystic medial necrosis gets its name because when this happens, the walls of the aorta develop cysts and necrosis in the medial layer. That's why it's called cystic medial necrosis. Everyone gets this to a mild degree with aging, but it occurs more rapidly in patients who have hypertension, bicuspid aortic valve, Marfan syndrome, and all these things are associated with thoracic aneurysms, as we just discussed. So commonly in patients who have ascending thoracic aortic aneurysms, aneurysms in this area, when you examine their aorta under the microscope, you will see evidence of this process. Some other things to know about the pathology of thoracic aortic aneurysms. First is that the medial layer of the aorta is very important. So remember, if we have blood in the middle of the aorta, we then have the intima, media, and adventitia. And this middle layer, the medial layer, is very important in the aortic wall. And that's because it contains a lot of connective tissue that provides tensile strength and elasticity so that the wall will be normal. It especially has proteins like collagen and elastin that give it these properties. So when this medial layer, which gives a lot of the strength to the aortic wall, becomes weak, that's what can lead to aneurysms. So many aneurysms in the thorax are associated with medial damage or destruction from hypertension and other processes. You should also be aware that the vasa vasorum is a network of small vessels that's mostly found in the adventitial layer. These are the blood vessels that supply blood to the walls of the aorta. When those blood vessels become thick, for example, from hypertension, that also weakens the medial layer. Even though these vessels are found in the adventitia, they will become enlarged, press on the medial layer, and the medial layer will become weakened. So once again, I'm mentioning these things so you understand that the medial layer is what gives the aorta much of its strength, and when that becomes weak, that predisposes to development of aneurysms. You should also be aware that tension on the wall of the aorta contributes to the development of aneurysms, and there's a lot of tension in the proximal aorta right here. Blood is expelled from the left ventricle and pushed forcefully into this area. That puts tension and pressure on the walls. This is worse if the patient has hypertension. So these are all reasons why you commonly see thoracic aortic aneurysms in this region here. In general, thoracic aortic aneurysms are usually asymptomatic, But you should be aware, especially for the step 1 exam, that if you have bulging of the aorta right here outward like this, it can pull the leaflets of the aortic valve apart, and that can lead to aortic regurgitation. And clinically, when we identify one of these aneurysms, we usually monitor them. If they get over 5 centimeters in size, that's about the size when surgery is recommended. The surgery is to replace the aorta with a graft, and that's done to prevent it from rupturing or causing an aortic dissection, which we'll talk about in a minute. Okay, so that's a nice segue into aortic dissection, which is the feared outcome of a thoracic aortic aneurysm. This is what we worry about happening if we let those aneurysms persist and get larger and larger. A dissection occurs when there's a tear in the intima. So once again, here are the 3 layers of the aorta. So if the blood is out here, this is the intima layer, which is in contact with the blood. Then we have the media, and then we have the adventitia. In a dissection, there's a tear in the intima, and it lets blood get into this space, shown in black here, between the intima and the media. And so blood dissects or separates the intima from the media. That's why it's called an aortic dissection. Most of these occur in the thoracic aorta. They're very uncommon in other locations. And they're usually preceded by development of a thoracic aortic aneurysm that enlarges over time until the dissection occurs. Aortic dissection is a life-threatening disorder, which I'll talk about in a minute, and it can be a surgical emergency because surgery is indicated for certain types of aortic dissection, and the longer you wait, the worse outcomes for the patient. This is a CT angiogram of a patient with an aortic dissection. You should learn to recognize these on CT angiogram because they're fairly easy to recognize even at the med student level. So this is the descending aorta right here. And can you see this line right through the aorta? That's a dissection flap. So that's one of the layers of the wall of the aorta, which has been separated from the wall so that there's blood on both sides, blood here and blood here. So learn to recognize this finding where you see the circular aorta with a line through it. That usually means a dissection. Fairly easy to diagnose by CT scan. To understand the clinical features of an aortic dissection, you have to understand that the dissections can propagate. Let's talk about what I mean by that. So blood enters the dissection plane, that area between the intima and the medial layers, and then it can spread proximally and distally. And when it does this, it can disrupt flow to vessels. It can even extend into the pericardial space, causing tamponade. So if you look at my little cartoon here on the screen, let's imagine we get a tear in the aorta right here, and blood starts to come in. Well, blood can spread downward, and it could disrupt flow into mesenteric vessels or renal vessels. It can also spread upwards like this, and it could disrupt flow to the subclavian artery and the carotids. It can give stroke-like symptoms. And then finally, it can dissect all the way back this direction and fill the pericardial space with fluid, causing tamponade. Clinically, we divide aortic dissections into 2 types, type A and type B. Type A dissections involve the ascending aorta and the arch, so this region here. These are treated with surgery because the outcomes of surgical treatment are better than the outcomes of medical treatment. These are the type of dissections that can cause aortic regurgitation. They can also lead to tamponade, which is the way people die from aortic dissections. Type B dissections involve only the descending aorta. These are usually treated medically. Most patients who have these types of dissections have severe hypertension when they present, so you control the blood pressure and the dissection will sometimes heal on its own, and that blood will eventually be taken up by the body. We don't usually do surgery for type B dissections because the surgical mortality is very high, higher than the mortality from medical therapy. The classic symptom of an aortic dissection is tearing chest pain that radiates to the back. Make sure you know this for your step 1 exam. In actual practice, patients can present with a wide variety of symptoms, sometimes vague symptoms. This can be a difficult diagnosis to make, and it's sometimes missed. But for your board exams, they're almost certainly going to tell you that the patient has chest pain, and they may describe it as tearing and radiating to the back. Other symptoms depend on where the dissection propagates to. So if it propagates to the aortic root, which means in this direction down towards the aortic valve, that's when patients can develop aortic regurgitation, which would be a blowing diastolic murmur on exam. This is where patients can develop pericardial effusions and tamponade. And remember, this is how people usually die from an aortic dissection. Also, the right coronary artery comes off right here and supplies the heart with blood. So patients can develop myocardial ischemia if the dissection obstructs the RCA origin. On the other hand, if the dissection goes this way and disrupts the vessels in the arch, then you can see stroke symptoms from disruption of blood flow through the carotids. You can see Horner syndrome, which I talk about in the neurology section. This is a disorder where sympathetic innervation to the face is disrupted. And you can also see vocal cord paralysis from disruption of the recurrent laryngeal nerve, which runs around the aorta right here. Other findings you can see on physical exam include a blood pressure differential between the arms. So imagine this is the aortic arch right here, and imagine that we have blood flow here going out to the left arm and blood flow over here going out to the right arm. Well, if the dissection only involves this area here, then you could get low blood pressure over here in the right arm and normal blood pressure over here in the left arm. That's called a blood pressure differential. Blood pressure should be close to identical in the two arms. When they're different, that's one of the findings you can see in aortic dissection. Another classic finding on X-ray is a widened mediastinum. So if you look at this X-ray on the screen here, this is the mediastinum. You can see it's very wide, and that's because the aorta is dissected and bulging outward. So the diagnosis of aortic dissection is suggested by the patient's history and exam findings like different blood pressure in the arms and chest X-ray findings like widened mediastinum. But the definitive diagnosis requires some type of imaging of the aorta. What's most commonly done is a CT scan. That's because these are available in most emergency rooms and can be interpreted very quickly. But MRI is also an option, and then in rare cases, transesophageal echocardiogram can also be used. But what you're looking for in the CT scan is this dissection flap right here, this line across the aorta, telling you that the layers of the wall have become separated. Also, it's interesting, but the D-dimer test, which you may know is a test used to screen for pulmonary embolism and DVT, is actually sensitive but not specific for aortic dissection. So in many emergency rooms, you'll see this test ordered in patients where they're worried about dissection. And the reason is because if it comes back completely normal, that makes aortic dissection very unlikely. If it's elevated, you have to do further testing because it is not a very specific test. The risk factors for aortic dissection are basically the same as the risk factors for thoracic aortic aneurysms. So hypertension is the number one risk factor because it can damage the aorta, and any pre-existing thoracic aneurysm is also a risk factor. Connective tissue disorders can predispose to rupture of the wall of the aorta. So Marfan syndrome, Ehlers-Danlos, these are both risk factors for aortic dissection. And then some of the others are shown here. I talked about many of these when we were talking about thoracic aortic aneurysms, bicuspid valve, Turner syndrome, tertiary syphilis. And there are many reports of patients who use cocaine developing aortic dissection because the cocaine raises the blood pressure, and that can lead to development of aneurysms or dissection. Okay, moving on. Now let's talk about abdominal aortic aneurysms, which are aneurysms that develop in the aorta below the diaphragm in the abdominal region. Aneurysms in this location are much more common than in the thorax. And the reason for this was always thought to be because there's a lot of atherosclerosis that occurs in the abdominal aorta. When I was in med school, I was taught that abdominal aortic aneurysms are a disease of atherosclerosis. And one of the reasons for this is because the infrarenal aorta, which is the portion of the aorta right here below the renal vessels, is the most affected by atherosclerosis, and that's the most common site of AAAs. Now, since I was in med school, there has been a lot of research that suggests that more factors than just atherosclerosis are associated with these aneurysms. There's genetics, environmental factors, hemodynamic, immunologic, lots of things contribute to these. But nevertheless, there is a strong association with the location of where these aneurysms develop and where atherosclerosis develops in the abdominal aorta. Shown on this slide are some of the important risk factors for development of an abdominal aortic aneurysm. And many of these risk factors, you'll notice, are also risk factors for development of atherosclerosis. So for example, smoking, which predisposes to atherosclerosis, is the strongest risk factor for development of AAAs. Men are 10 times more common to develop these aneurysms than women. Age is an important risk factor. These aneurysms are rare before age 55, and as many as 5% of men over 65 have one of these aneurysms. And then finally, hypertension, hyperlipidemia, these are all risk factors for AAAs. Most abdominal aneurysms are asymptomatic. Sometimes they can be detected on physical exam. The classic finding is a pulsatile mass from the xiphoid to the umbilicus. So when you examine the abdomen, you can feel pulsatile mass in a patient with an abdominal aortic aneurysm. The natural history, if these are left untreated, is that they enlarge, and then finally they rupture. And when they rupture, patients present with acute abdominal and back pain and hypotension. This is a life-threatening surgical emergency. We screen patients for these aneurysms, especially older patients who are smokers and have hypertension, with ultrasound, or sometimes CT scan, but more often ultrasound. And surgery is done if they grow to become more than about 5 centimeters, because at that point the risk of rupture is significantly high. And then finally, I'll finish with one slide on aortic rupture, which is a condition where the entire wall of the aorta ruptures and blood is allowed to leak out. This usually occurs in patients with major trauma, And it's high yield to know for your board exams that the most common site of aortic rupture is the aortic isthmus. This is the isthmus right here. It's the portion of the aorta just beyond the takeoff of the left subclavian and before the insertion of the ductus arteriosus in the fetus, which is about here. And it turns out developmentally that this is a relatively weaker portion of the aorta compared to other sections like the descending aorta and the ascending aorta. So this is where ruptures tend to occur in patients who have major trauma. And that concludes our video on aortic disease.